And in today's journal club, I've selected a modeling paper titled Estimating the Impact of COVID-19 Vaccine in Inequity. Now, before we dive into our group discussions, can you see my screen right now? Sorry. Can you see my screen?
It's visible. Yeah.
Okay, so I will provide a very brief overview of this paper, and I know you guys are much better than modeler than me, but in this summary, I will omit the most of the technical details of the modeling process while focusing on what kind of aspects they incorporate into their model and highlights the key takeaways. And while discussions on vaccine inequity in the context of controlling infectious disease exist before the COVID-19 pandemic, but the issue has intensified, sparkling numerous debates during the pandemic. And I think this is because that almost the identical urgency across countries to achieve a widespread vaccine coverage with a limited supply has heightened this socio-economic structural inequity or disparities in assessing the COVID-19 vaccines. And in response to this challenge, the COVAX program, officially known as the COVID-19 Global Vaccine Access Program, was initiated in April 2020. And this is a multilateral effort involving the various world organizations, including the UNICEF, WHO, CEPI, and Gavi, and to ensure the global equitable access to COVID-19 vaccines. And this COVAX also launched the vaccine delivery partnership, focusing primarily on distributing vaccines to the 34 countries that had a vaccination coverage at or below 10% in January 2022. And despite these efforts, the vaccine inequity remains unresolved yet, I think. And while the total vaccine distributions per 100 people by October 2021 even exceeded 100 persons in high or upper middle income countries, in stark contrast to lower and middle income countries where substantially lower level persist. And additionally, robust correlations can be shown between the cumulative vaccine coverage and the Human Development Index here. And then moreover, not only the vaccine coverage, the timing of vaccine rollouts, specifically when LMIC have access to vaccine, is also very crucial. So this figure shows the evident delay in vaccine rollout within the LMICs. Now, to address these issues, mathematical modeling approaches has been widely employed to assess the potential impact of equal vaccine distributions. And Wagner et al. Presented a great paper in Science in 2021, wherein they created two synthetic populations with a high and low vaccine access and explored the potential epidemiological and evolutionary consequence of vaccine inequity. And their findings suggest that increasing vaccine access may lead to a reduction in total case across regions and mitigate the potential for the antigenic evolutions, which may result in the emergence of new variants that affect the epidemiological characteristics globally. And if you have more interest on it, please check this paper later. And while this study, this paper efficiently highlights the importance of the vaccine equity, it relies on a little bit theoretical simulations with a limited empirical data. So that's why I selected today's paper, because these studies aim to quantify the impact of vaccine inequity on the COVID-19 burden in 20 LMICs across WHO regions using various empirical data. And the way they quantify the impact is based on these two counterfactual scenarios, which are the what if the per capita vaccination rate in LMICs would be the same as that of the US. And the second one is what if the vaccination rollout starts at the same time as in the US. And they intentionally selected 20 LMICs from all WHO regions where the empirical data, including number of deaths and vaccination coverages, are available. And notably, due to the geographical characteristics of these LMICs, majority of selected countries are located in either Africa or Southeast Asia, as you can see here. And these are the empirical vaccine coverage. While Sri Lanka and Morocco showed relatively higher vaccine coverage, if you see the comparison with the US or Israel, this is the US one and this is Israel one, highlights that significantly delayed the timing of rollout in these countries. Now, additionally, the rest of included countries showed a substantially low vaccine coverage across the study period. And now let's take a brief look at their model. So they employed an SEIR like age-structured stochastic compartment model, considering 10 age groups, and the simulation period ranged from the October 2020 to October 2021. And notable strength of this study lies in its reliance on various country-specific empirical data, including contact patterns by age group and variant proportions. And particularly interesting is the use of Google Mobility reports to model the impact of non-pharmaceutical interventions, which is NPIs, on SARS-CoV-2 transmissibility here. And this study assumes that all changes in mobility were solely driven by the changes in NPIs, which might be a reasonable assumption, especially in the early phase of pandemic, considering the simulation period. And also it can be a very efficient modeling approach without need to search for specific implementation dates of NPIs in each country. And lastly, the model was collaborated with a reported death accounting for the potentially low case ascertainment rate in this LMICs. And they employed approximate Bayesian computations approach based on the sequence of for collaborations. And also like these are the parameters they estimated, and considering the low diagnostic capacity in LMICs, the model also additionally incorporates the reporting probability in death, adding another layer of complexity to their model. And this is how they modeled the vaccinations here. So given the study period, only the first and second dose were taken into account, and no waning immunity was assumed in their study. So the vaccine effectiveness was can be calculated as 1 minus vaccine effectiveness against infections, which reduced the transmissibility in their models, divided by 1 minus vaccine effectiveness against death, which reduced the IFR in their model. And immune response was considered to initiate 14 days after vaccinations. And also they considered the reduced infectivities among vaccinated individuals when they infected. And this is the results. What if the LMICs had a US equivalent vaccination rates? And as you can see in these figures, for more than half of the included countries, the percentage of death averted exceeded 70%, with the peaks above the 90% for Afghanistan and Uganda, where significantly low vaccine coverage was reported. And the second result is, what if the LMICs started vaccine rollout with the US? And as all countries distributed vaccine in different timings, so the delay with respect to the US starting date spans 1 to 4 months by countries. But overall, it was projected to reduce the 20% of death, while the magnitude of such effect is heterogeneous and smaller when compared to the previous counterfactual scenarios with more vaccine doses here. And in addition, so here the key factor is the interplay between amount of vaccine available and relative shift of starting times. So what it means that in countries with extremely low vaccine coverage, shifting the start of vaccines rollout may not result in a substantial decrease in death here. And the last result is this figure illustrates the necessity stringence of NPIs to align with the death averted given 4 months of implementations. So in other words, it indicates how much transmissibility should be reduced to achieve the same level of death reductions as when LMICs had a vaccination rate equivalent to that of the US. And most countries need to maintain 40% reductions for 4 months. And if you record your life in 2020, like maintaining such stringent interventions for 4 months will be very tough, causing non-negligible economic and societal issues. And also like interplays between the length of implementation and its extent, that is a decreased transmissibility is again important here. So in this context, observing the dysgona, that it becomes evident that achieving 90% reduction in transmissibility is necessary when shortening the intervention length to 1 or 2 months. And such a requirement might pose significant challenges unless implementing extremely strict lockdown measures coupled with a highly active testing within 1 or 2 months here. Now, there are some caveats here still. The caveats are incomplete consideration of vaccination details. Like even though like they considered many details of vaccinations, still they didn't consider the different characteristics by vaccine type and geographical heterogeneity, which can be the additional layer of inequity within each country. And also like they assumed the constant uncertainty rate in death was assumed here. And also like the optimal vaccination stretch was not considered in assessing the potential benefit of vaccinations. So what I mean is that in Ben Cowling and Hong Kong University proposed a brilliant ideas in 2023, I think 2020, I don't know, like 2023 maybe. And the idea was a fractionation of vaccine dose. And this concept stands as a potential solution to the global shortage of vaccines while increasing the overall immunity level robustly. So like if we apply such optimal vaccination strategy, it could this kind of like vaccine equity could potentially lead to even greater reductions in averted death than the currently projected one. And yeah, this is the end of the brief overview of this paper. And I just brought like 4 discussion points here. So the first one is in assessing the vaccine equities using the mathematical modeling approach, what other aspects can be taken into account in addition to changing epidemic outcomes? That's my first question. And the second question is how can you practically realize such vaccine equity during the pandemic? So like my questions are we ready now? And also like how well are we addressing these challenges, this vaccine equity challenge in the context of the global mpox outbreak or so on. And like last question is my personal curiosity, but I often wonder whether this vaccine equity is always advantageous or if there are specific situations where prioritizing equity might inadvertently increase the overall burden. So while I generally love the idea of the vaccine equity, I thought it would be fun to discuss if there are any potential adverse consequences associated with having this vaccine equity. Yep, this is all I have today.